Hello and welcome to this lecture on whole body and blood-based, non-imaging based dosimetry. My name is Taprogge and I'm a medical physics expert at the Royal Marsden Hospital in the UK. I have nothing to disclose in relation to this presentation. So, like I've said in one of my earlier lectures, so when we're looking at how much activity we can give to patients, we're often limited by normal organ absorb dose limits, and very often this is the bone marrow. And we need to kind of limit the amount we give to individual patients to minimize the risk of toxicity. So if we're looking at the bone marrow, kind of like the soft spongy tissue in the center of like most of our bones, and they're really there to like produce really important bits in our body that like if we kill off the bone marrow, we're really ending up with a problem. So red bone marrow, for example, produces like the red blood cells, white blood cells, and platelets. So that if we're killing off that one, we often kind of like see anemia, like where we like decrease the number of red blood cells, or neutropenia, where like the kind of neutrophils go down. And the yellow bone marrow, on the other hand, is kind of like what produces the cartilage, the fat, and the bone cells. So it's really like an important bit, and so it's really important to minimize the risks of toxicity. And so what we're obviously doing often is kind of like looking at the absorbed dose delivered to the bone marrow to use that to predict our kind of grade or like our amount of hematological toxicity, where we kind of like see decrease in bone marrow blood cells in our patients. And then on top of that, the bone marrow dosimetry really can also help us to prepare any kind of stem cell transplants or stem cell support, and to ensure that we give that at the right time to the patients. So looking back, it's really been around for a long time, this kind of like concept of blood-based dosimetry, and was really started off in the 1960s by Benoit et al., who kind of proposed this blood-based dosimetry for radioiodine therapy in thyroid cancer patients. And they proposed that it's safe to treat up to a blood absorbed dose of 2 gray, while we also have to keep the whole body retention less than 4.4 gigabecquerels at 48 hours after the therapy, and to kind of like limit the pulmonary uptake to less than 3 gigabecquerels at 24 hours. And kind of like looking a little bit more deeper at the kind of like that 2 gray limit, there's this data from Lashforth et al. That really nicely shows it. So they looked at different kind of normal organ toxicities. So they looked at anemia, at neutropenia, but they also looked at like renal toxicity for patients treated with I-131 MIBG for neuroblastoma. And they did treat patients with different amounts of whole body dose. So they had a couple of patients treated with 1 gray, lots of patients treated with 2 gray, and so the similar amount of patients treated with 2.5 gray. And like in all of the graphs, you can really see, so red is 1 gray, green is 2 gray, and blue is 2.5 gray. We see that like on the WHO toxicity grade range kind of thing, for the red and the green, we're really like down to like the lower WHO toxicity rates, like usually less than 3. And it's only when we're going to kind of a 2.5 gray that we're actually ending up with quite a lot of patients that have had grade 3 or grade 4 toxicity. So it's really like establishing kind of like this kind of like 2 gray limit that we're normally working towards. And so when we're talking about bone marrow dosimetry, there's obviously different potential contributors that contribute to our total bone marrow dose. And it really depends on where the activity distributes in the body, and even where it distributes in the blood. So we have to kind of like look at, is there activity actually in the bone marrow itself? Is there activity in the bone marrow cells and the extracellular fluids? Or is there activity in the blood or the blood components? Is there uptake in the bone that will also contribute to our bone marrow dose? Is there any activity in other major organs and the remainder of the body that kind of like contribute to our total bone marrow absorbed dose? And all of those kind of individual contributions really will depend on the pharmacokinetics of individual radionuclides and tracers that we're using. So it's really important that kind of like the bone marrow dosimetry schedules really have to be adapted to different kind of like radionuclides that we're using. So when we're looking at kind of like what data we should acquire for our blood-based dosimetry or whole body-based dosimetry, it really, like I said, it depends on what tracer or pharmaceutical we're looking at. So we might either be acquiring just whole body dosimetry, we might have to do blood sampling, or depending on where the uptake is, we might also have to do quantitative imaging to like look at uptake in bones or something like that. And then really the kind of like how often we have to sample and like at what time points will really be governed by the pharmacokinetics of the different radiopharmaceuticals that we're using. And it's really like I've highlighted here like 2 of the A&M guidelines. It's really like important to look at those guidelines and like figure out what you want to do for like the different radiopharmaceuticals that you're using. So this is from the A&M guidelines, and I think it's really like a little bit of a flow chart showing you what kind of data you have to acquire depending on where the uptake is. And so we're always talking about measuring the activity in the whole body. That's fine. And then it depends on if there's uptake in the bone or the bone marrow. Then you might have to use quantitative imaging and estimate your bone marrow mass. If there isn't, but if you know that there's uptake in any kind of component of the bloods, and you need to measure the activity in the blood, you need to determine kind of like your hematocrit, the ratio, and then you might have to either measure the activity in the plasma, or you find it's just measuring the activity in the blood. So this really kind of like shows you like a nice flow chart of like how to decide what kind of data you need to acquire. And then there's just a little bit of a reminder. Obviously, there was a whole lecture on whole body data acquisition, about the kind of like what kind of counters you can use. So when we want to measure the activity retention in the whole body, we need either serial whole body images or radiation detectors. And like I said before in the other lecture, it's really about like you can use ceiling mounted detectors, you can use handheld radiation detectors, and as long as it's all in a fixed geometry. You should take as much readings as you can, and very important, it's kind of like to take a baseline measurement after the administration, but before the patient has gone to the toilet, with anterior and posterior acquisitions, so that you kind of like can set your baseline, and the anterior and posterior acquisitions kind of like to allow you to do your geometric mean at each time point. And then, so I didn't talk too much about it in the whole body lecture, but like the sampling schedule really is an important one. And this is data from one of our MIBG patients. So like I said before, treatment schedule is 2 + 2 gray to deliver a total whole body absorbed dose of 4 gray. And so this was the example I showed before, where kind of like the whole body dosimetry for the first treatment ended up with roughly 1.4 gray. And that is then used obviously to calculate how much activity we're giving the patient for the second treatment. So it's really important to get that number right. So this is kind of like showing all of the data we have acquired. So now I'm just going to run through a couple of kind of like examples. What if we wouldn't have acquired all of that data? And so the first bit is where I'm kind of leaving out any data that was acquired after 72 hours. So I'm not fitting my function to that, my whole body retention to that anymore. I'm discarding any data that was left after acquired after 72 hours. And suddenly I end up with a whole body dose of 1.3 or 1.25 gray, so significantly smaller than what we had before. So if I would use this data to kind of like predict how much I have to give in the second treatment, my patient would have received more activity and potentially more dose in the second treatment, and overall I would have potentially over-treated the patient. Second bit is, like I said, it's important to kind of like to take lots of measurements, especially if we're fitting multi-exponentials and everything, and also kind of like to discard any like erroneous measurements that there might be a problem with. And so this is one where I've kind of like discarded quite a lot of the intermediate measurements and just chosen randomly some of the measurements. And now instead of the 1.35 gray, I suddenly end up with 1.46 gray. So the patient would have received less activity in the second treatment, would have potentially been undertreated. So it's really important to kind of like to get that whole body sampling schedule right. So the next bit I want to talk about is the blood sampling, because the activity in the bone marrow can be determined from blood or plasma samples if we assume that there's no specific uptake in the bone marrow cells. And so ideally, we measure the concentration in the blood and then the plasma, and get the hematocrit to kind of like relate those two to each other. And any blood samples should be taken from the arm opposite the injection site if the injection has been given IV. And then really something that's really important is as well exact recording of the timings of the different blood samples so that we can accurately draw our time activity curve. Like I said in the beginning, it might be necessary that if we suspect there is specific uptake in the bone marrow or in the bone, then quantitative imaging really should be used. And like there is the imaging lectures 1 and 2 that you saw earlier as part of the course, that you can have a look at to actually go into depth into kind of like what is needed from a quantitative imaging perspective. So I don't want to spend too much time on this here. So in the next bit of the presentations, I'm really going to talk about one example, which is where whole body and blood dosimetry in thyroid cancer patients and how it has been used, and show a little bit of more details of like what kind of schedules you should be using for the acquisitions and what kind of data is needed. So for the example of thyroid cancer patients treated with radioiodine, the ENM has published guidelines in 2018 on like how to perform personalized treatments based on the blood absorbed dose, using pre-therapeutic low activity I131 administrations. So before the therapy, which then are followed by a series of whole body and blood measurements to calculate the blood absorbed dose or the bone marrow absorbed dose for those patients, to then tailor the activity that they get at therapy based on those measurements. And so they've got this like timing schedule in their guidelines, which I find very good, because it gives you an example of like what kind of measurements are needed and when they should be done. So before you do the kind of like administrations, you perform your kind of like QC checks and all of your detectors and everything. You prepare like I131 standards for the blood dosimetry and everything for your gamma counters, and then you do the trace administration for the patient after they've been to the toilet, and then they administer the tracer activity to the patient. And then depending on if it's IV or oral, it's either 10 minutes or 2 hours afterwards. You kind of like do your baseline measurements with whole body retention in a blood sample. And then at 6 hours, 24 hours, 96 hours, and 144 hours, it's always first the patient goes to the toilet, and then there's a whole body retention measurement, and the blood sample is taken at all of those times. There's an optional step at the end where at the last measurement, the blood sample might be skipped, depending on what is clinically possible. So they then provide this equation in the guidelines, which helps you to calculate the absorbed dose to the blood per unit administered activity. And it has kind of like 2 parts to it, like a bit that belongs kind of like to the absorbed dose to the blood component, so which means you counts for the kind of like contributions from the beta radiation. So that's the first bit of the equation. And then the second bit accounts kind of like for all of the decays outside the blood, but they still contribute to the blood absorbed dose by kind of like penetrating radiations. So again, you've kind of like a factor that is actually includes the patient weight as well, and then for both of them, you have kind of like your residence time in the different bits. So you've got like the residence time in the blood and the residence time in the rest of the body or the whole body. And that to get all of that together then gives you the blood absorbed dose per unit administered activity. There have been proposals out there to actually, instead of like calculating the absorbed dose to the blood, to actually calculate or use a modified formula to calculate the absorbed dose to the red marrow instead. So the red marrow dose usually is less than the dose to the blood, usually between like 10 to 30% smaller. And we have got kind of like this this formula for that, again, just a dose to the red marrow per unit administered activity, and very similar as before, kind of like a component that takes into account like your blood samples, and then a component that takes into account anything that comes from the rest of the body. There have been over time lots of proposals to kind of like simplify those schedules, because obviously, especially if the patient has to come in prior to therapy multiple times to like the whole body measurements, blood samples, and everything, there has always been a push to kind of simplify the things. So, and I think the first bit was done by Thomas et al., who kind of like proposed to remove the necessity for blood samples in thyroid cancer patients and to use whole body measurements only. And that was followed then later by Hanschen et al., who actually went away from using multiple whole body measurements, but said it was possible to use a single measurement of the whole body retention in differentiated thyroid cancer patients. Best accuracy they obtained was when that measurement was done 1 to 2 days after the administration. The only problem is obviously these are all simplifications. So you always kind of like, you have to assume certain half-lives or retention patterns and everything. And there very much is a risk of underestimating the blood absorbed dose. So you have to be kind of cautious when you're very close to the 2 gray limit anyway. And then you might need more sophisticated schedules, taking into account multiple whole body measurements or even blood samples. So yeah, kind of like just to summarize, I think bone marrow dosimetry really is an essential bit that we can do to like limit hematological toxicity, especially if we're trying to like increase the amount of activity we want to give to patients. And I'm going to be talking more about that in one of the later talks, where I talk about like radioiodine dosimetry. And the complexity of the measurement schedules very much depends on kind of like what radiopharmaceutical you're using and what the pharmacokinetics are and everything. So and like I said, there's lots of work has been going on trying to simplify the schedules, but yeah, there's lots of E&M dosimetry committee SOPs and guidelines out there that kind of like try to guide you into what number of measurements and what types of measurements are needed. And yeah, so the only thing I have to say at the end is really we still need to work further on kind of like to assess more of the dose to toxicity relationships for a wider range of pharmaceuticals, and to kind of like bring that into clinical practice. So thank you very much for listening, and I hope you've enjoyed the talk.